Good afternoon, ladies and gentlemen. A warm welcome from Sri Lanka. And at the onset, I'd like to give my thanks to the American College of Sports Medicine and the organizing committee of the annual meeting. And the Exercise is Medicine, Older Adults Committee. And also the chair of this symposium, Mike, who is the chairperson of the Older Adults Committee, and the previous speakers, my colleagues Jamal and Jeff, and also giving me this time, give a small brief about exercise is medicine, translating research into practice, and especially on increasing physical activity in older adults symposium. So strategies for changing perceptions and behaviors towards physical activity is the topic, and I'd like to draw your attention to some of the cognitive behavioral models that we are using in patients and in clients, and how we can use them in the older adult population. So brief just introduction about me. I'm a sports and exercise medicine physician and also an academic from University of Colombo. And so I'm from Sri Lanka. Just a brief about a country which is situated in the Indian Ocean, just under India. So in South Asia, which is home for about 1/5 of the world population. And Sri Lanka is an island nation, a low and middle income country, with a population roughly about 20 million, a multicultural community. And it is in a socio-demographic transition, whereas rising non-communicable diseases, and also a fast aging, one of the fastest aging populations in the region. Which we are predicting about 1/3 of the population will be more than 65 in 2030. So that's we are expecting a lot of older adults in our community. So this is where I work, one of the oldest medical colleges in the region. We just had our 150th anniversary recently. And this is my unit. Apart from the sports and exercise unit, medicine unit, apart from the clinical services that we provide to athletes, we do physical activity promotion at the communities in the ground level, and also clinical exercise prescription in our exercise clinics. So the slides that I'm coming up is mainly coming from the literature and also the experiences that we have with the patient, and also some of the research that we have done in this local community. So this third part of the symposium, the strategies for changing perception and behaviors toward physical activity or exercise. I mean, if you really think what is physical activity or what is exercise now, exercise is a health-related human behavior influenced by cognition. So it's a behavior that we engulf, we inculcate, and continue. So it's just like other health behaviors, or that we as clinicians looking at things like eating habits, alcohol consumption, harmful alcohol use, smoking, drug abuse. These are also taken as behaviors. And in clinical subject, the behavior modification is one of the factors that when we attend these patients. So just like that, exercise is also a behavior. It's not a harmful behavior, but it's a good behavior, that how we can incorporate that into life is one of the tasks. So cognition and behavior makes a significant part of adoption and maintenance of this exercise behavior. So cognition and behavior plays a major part. So if there's an individual, older adult or a normal person who is novice, who has no experience in exercise, requires a significant behavioral change compared to a person who is used to do exercise who has a previous experience on exercise and coming to do get an exercise prescription from you. So if there's a novice, it is a bit of a difficult thing when you meet them to change their behavior. So our main topic is an older adult. What is an older adult? Of course, the age more than 65. And when it comes to exercise, most of the time, the person can be a novice. A person who has never done exercise before, who's coming to you to do exercise, or I would just use the word exercise, but it can be endurance exercise or strength training, balance training, agility training, whatever which is needed for that patient, is maybe has not done that before. So comparing in our population, where in South Asian population, this is even more. Most of these people in this region are not exposed to recreational exercise, but most of the time their physical activities is through transport and work-related physical activity, not recreational type. So their perceptions regarding exercise is new and sometimes may not be that supportive. Of course, older adults is fragile. So that is also is why we are prescribing exercise, but that is also can be a barrier to produce exercise, and also the injury risk. So older adult is a person like that when it comes to changing behavior. So normally what we normally do, as discussed in previous sections also, we do prescribe a dose of exercise. Technically, we prescribe a dose of exercise that needs to give a health benefit. So normally we go by the FIT principle: frequency, intensity, time, and type. So if it's aerobic exercise, say 30 to 40 minutes, moderate intensity, 5 days per week of walking, moderate intensity walking. So that would be an aerobic prescription. And strength training also, say, okay, 50 to 60% or 70 to 80% of repetition maximum, 8 repetitions into 3 sets of a specific muscle group. So that would be the dose that we want these people to do, right? That's what we do, and then we are happy that they will do it. So we expect them to do that. If not, they will not get the benefit. So what if they don't? So that's where the problem comes. When we are thinking about an older adult with all these complications, problems, if they don't do, then our exercise, the way what we expect is not being achieved. So when we think about that, is where the other domain, just like the technical domain of exercise prescription, there's another domain which is missing, which we have been discussing in different classes in small bits and pieces, but it's a specific area where research has been done. The cognitive behavioral domain is being addressed most of the time, but not as an entity together, that it is one of the other part which coexists with the technical domain that we have to do for supervision or prescribing or exercise counseling. So that is what I would like to draw your attention to. This domain, as exercise physicians or exercise physiologists, physiotherapists, we are mainly changing behaviors, but we are not very much exposed to these cognitive behavioral theories, which has been extensively studied, developed, and there are more than 5 decades and a lot of theories, but they are not very much integrated into exercise supervision as an entity. Not like maybe on prevention of smoking, prevention of alcohol, and even prevention of harmful drug use. These have been extensively used, but not very much in our context. So I'd like, with our review, there are about 5 most commonly used theoretical models which we see in the literature, especially used in health behavior change interventions, not only exercise, but other interventions also, namely the trans-theoretical model, which I will describe in the coming sections, and social cognitive behavioral therapy, theory of self-efficacy, self-determination theory, theory of planned behavior, and the health belief model. Now, these are very complex theories, and I'd like to bring out the essence or the main constructs of these models and how we can use to improve the adoption and maintenance or the uptake of physical activity in the older adult. So we did a review, and we used these and developed a model, and we have used that model in our population also, which we have seen some good results when we use it as a separate model. So this is the paper, and the reference is also given at the end of the slides. So number one construct is, or the extract is the theory of the stages of change, which we commonly, most of the people must have seen this or heard this, the trans-theoretical model, which discusses about psychological stages a person is in when he or she is going through a behavioral change. So normally the person, all of us would be in different stages when it comes to or exercise or any other behavior. So as an example, if there is a person, a gentleman who is going to a doctor, maybe for diabetes, and the doctor advises him on prescribing, getting on with doing exercise, maybe strength training, maybe aerobic training. So at this point, this person who has never done exercise and never heard of it, he really doesn't know the importance of exercise. So that is here, he doesn't know. So that is the pre-contemplation stage. Then after knowing, he will think of doing it or not doing it. So that's the contemplating stage. And maybe he will meet the referral or get on with the person who wants, maybe a exercise physician or an exercise physiologist, and get on doing it, and at the same time he might not do it also. So if he get on with doing it, then he will be in the action stage, and he will try to maintain. Now during action, the problems, the barriers, the limitations will be there for him to continue this exercise, and we will discuss what they might be. And there can be a relapse, or maybe he will maintain. If he get himself injured or herself injured, that can be a factor that he will go out of the behavior, he'll stop doing exercise. And then he or she might just stop or come back if there's proper motivation and support is given from the clinician. So the clinician, what I'm trying to tell you is, people will be in different states of mind, and for them to go to the next stage, they need support, and this support can be different depending on the stage that they are in. So as exercise professionals, we need to at least identify which stage this person needs to support and motivate the person to get on with this behavior and continue it, adopt it, and also maintain it. So that's what the stages of change or these trans-theoretical model tells us. The second extract is, of course, the belief of the person. This comes from a couple of theories like health belief model, exercise behavior model. And what it really says is the person's subjective belief about three things. One thing is about the health status and how exercise relates to the health status. So for an example, the person might not really understand the importance of exercise unless he really meets a big challenge, maybe a myocardial infarction, maybe a heart attack. Then he realizes it's very important and get on doing it. So how it relates and how it is important is one thing that we need to understand when it comes to behavior behavior modification and behavior change. So the second construct would be the exercise, whether it really helps. The belief regarding exercise, whatever we say, do they really believe whether it actually helps? So these things, what the patient's beliefs, are very important for their next move. And also their beliefs regarding the provider or the prescriber or the exercise physiologist regarding their competence. Now, these are older adults. As I told you, they have a fear of risk of injury, and the competence, whether, because normally there's a general thinking that exercise can injure. So the competence has shown that if they are very competent, both technically and also change in behavior wise, it has shown the uptake or the adherence is better in exercise programs. So prescriber needs to understand that the client will have subjective belief, and that if they understand that belief, it will help to motivate the client. So these are the models these constructs are being derived from. And the third one is the ability of the patient. So ability can be two levels. One thing is the ability to make autonomous decisions, or the autonomy of the patient. If they can make decisions regarding themselves, that has shown the uptake is better, and they are highly satisfied with the decisions that they take. But some people are not like that. They need a lot of support. So identifying whether your client is able to make autonomous decisions and supporting it is is what you call by ability. So ability is one important construct that maintains or adopt and maintain the exercise behavior. And the other ability is, of course, when you start doing exercise, when you prescribe for an older adult or any person, if you are new to it, it will take some time for you to get on with it. But if you become better doing it, and if you start getting benefits out of it, the adherence to exercise is better. So that's what we call the perceived ability of the client to perform what we ask them to do, maybe lifting of weight. So that is called self-efficacy. When you can, you do better. So you enjoy it. So improving self-efficacy, at least from the perceived level, has shown improving adherence to the exercise behavior. So autonomy and self-efficacy are the ones, and the relatedness of what you do have shown increased uptake when you are addressing these two constructs as a person who prescribes exercise. So even everything is fine. As I told, these are adults who have a lot of limitations. So need to be sensitive about these limitations, which will start coming maybe after starting exercise, or maybe even before at the contemplating stage, that the limitation can hinder the adoption of exercise. And even after that, the barriers will be there to maintain this exercise behavior. So as we discussed, health status of the adult, a lot of complications, comorbidities is a limitation that the prescribing need to be very sensitive about, because if they feel that it is not being looked at, the safety issue, so then the client might not adhere to what you say. And of course, something more global, the culture. Different people will be in different cultures and backgrounds, and their beliefs regarding exercising, maybe in public, maybe in a gym, maybe even what you wear. Especially where I come from, there are a lot of ethnicities that we meet. And one of the examples, like Islamic ladies might not like to exercise, not everybody, but some might not like to exercise in the vicinity of especially the older generation in front of male counterpart. So it's not for everybody, but these cultural beliefs also might be important when you are prescribing exercise. And of course, the time is a very important factor which limits exercise uptake, especially in the productive age group, because they don't have time to do exercise. That's one of the main complaints. But the older adults have time, but what they don't have is their caregivers don't have time. If they're dependent, they might not have the person to bring to you and come to you to do exercise. So lack of time of the caregivers is a limiting factors of older adult group. Of course, the other thing is accessibility to a specialist provider and the accessibility to infrastructure like a gym or a special place to come and do exercise. So it might not be there in the developed world, but in the developing world, we don't have very much gyms which are accustomed to older generation, and also who are specialist prescribers who can handle this type of population, who are really trained. So we see that even in Sri Lanka, that we don't have much people who can handle a vast population. So accessibility to a trained person and also to a trained infrastructure can be difficult, but we know that with a trained person, even without infrastructure, we can do strength training and other types of things. But then again, it's something that we need to think of when we are prescribing exercise. And they might not tell you, but at home they will go and they might not do. So complexity, if it is complex exercises, high intense exercises, maybe initially it will be difficult and they might reject, and it will reduce the self-efficacy. So especially we have been talking about strength training. We know there a certain amount of strength, 70 to 80% of 1 RM is needed to receive health benefits. But I think that should be given slowly and progressively, going into that target, thinking that sometimes if it is high intense difficult ones, they might reject, and that is something that we have to play around and slowly and progressively get to our target. So fifth extract or the construct is obviously the most important for adherence, is the satisfaction. So it is the main driving force of adopting and maintaining of any behavior. If you are enjoying of what you are doing, you will add on. So when we are prescribing not only the technical component, but getting them to be socially interactive and support their whatever the other needs that they have, socializing, all these things are important. And also whether our exercise behavior could be competed with the other behaviors they will do at their leisure time, like watching TV or reading. So these are things, that small things that you have to look at, and these are being discussed in literature and being used as methods to improve physical activity uptake. And also what are the most important thing to an older adult is to live their life productively without injury and with high quality of life during their the time that they spend. So whether the activities are relevant to them, whether the activities are daily living is improving with these exercises, is also something that will satisfy them and keep them adhered to the exercise. So if it is easy and exciting, easy in the sense easily adopted, and even the resistance, even the intensity is high, easily they should perceive that it is that something that they can do, and it is exciting, which has shown the adoption is more. So out of these 5 constructs that we have derived from these different overlapping cognitive behavioral models, we just developed this model called Fitzwald model. So it's like a sphere which has all these components, the technical and the cognitive behavioral components, and the technical components is of course the frequency, intensity, time, and type. And SBAL is S for stage, B for belief, A for ability, L limitation, and life satisfaction. So what it does is that it shows that these two things are connected together, and it is connected to each other. Each construct is connected to the other. So it is a multiple interacting dynamic type of a tool that for us to visibly identify the complex nature of exercise prescription or behavior change. And if we do it well, the sphere will roll and keep on the person adhering to exercise. But when the barriers come, they might hit somewhere in one of these constructs. And if we try to change that construct, then again, the adherence will be there. So it's just a graphical representation showing that these two constructs should be there, and we have to look into the cognitive behavioral models, especially in older adults, because they need a lot of effort to change behavior if they have not done exercise before. So, out of this brief talk, my take-home message is exercise prescription. There are two domains coexist according to the vast current literature and also our experience. So it's like a dynamic model which has the cognitive behavioral component and the technical component. So we have to appreciate the coexistence of that and put our mind into changing behavior and cognitive behavioral components also. So that's from me, and thank you very much for listening. These are my references, and I hope that I would have been there, but unfortunately I could not be there. So thank you very much again listening to me, and if you need to contact me, thank you, and this is my contact details. And over to you, Mike. Thank you very much. Have a good day.